for supporting this important events, which is coming in a timely manner. Only less than about 10 days before Ramadan. So I'm going really to address the topic, which is integrating CGM in the care of diabetes during the month of Ramadan. My focus will be primarily on type 2 diabetes. My dear lead will address technology in type 1 diabetes, and this is why I'm going to, as much as I can, stick to type 2 diabetes. So in this presentation, and this is my this is the outline of my presentation. I'll start by an introduction and going through with you through the potential advantages of continuous glucose monitoring during Ramadan. I'll go through the CGM metrics, and when I talk about, cannot skip really addressing the accuracy of the tool that we have at our disposal, because it's important to have an accurate CGM in order to make important decisions. CGM and diabetes during the month of Ramadan. The technology and what the guidelines say, applying the CGM guidelines to mitigate hypoglycemia in high-risk patients, CGM metrics in Ramadan. And before I go through my summary conclusion and take by the introduction and the potential advantages of CGM during Ramadan, if we can refer to this study, which is now really 10 years old, the CREED study. The CREED study, which is observed different aspects related to fasting in subjects with diabetes. And what it showed essentially is that there's a high prevalence of fasting despite medical exemptions. So, and this is what we see every day. So there's nothing new about that. You ask people, are you planning to fast? Even the extreme high risk groups will say to you, yes, I'm going to a safe way. It's important to keep in mind that fasting the duration varies significantly according to the geographical location. And because of this, the advice that we offer our patients should be individualized. So there's no one size that fits all. And it's important, obviously, to mitigate risks, particularly related to hypoglycemia and diabetic ketoacidosis. So if you look at the CREED study, what it showed essentially is that even the high risk, if you look at subjects who fasted, you can see that high risk group were a quarter and the very high risk group were a quarter as well. So most of the patients who are fasting belong to the high risk and the very high risk groups. Ibrahim in BMJ, he reviewed with us the changes that we see during Ramadan. So as we can see that he highlighted the fact that will go up and catecholamines will go high. So this is really the natural body defense against hypoglycemia. This is what our body does for us to protect us from the hypoglycemia. And there's enhanced glycogenolysis and gluconeogenesis to maintain euglycemia whilst fasting. In people with diabetes, some of them, particularly with long duration diabetes, there's loss of the counter-regulatory mechanism, and that increased the risk of hypoglycemia. Ramadan also, there's the issue of postprandial hyperglycemia, more so after iftar fasting, thanks to the rich carbohydrate meal that people consume. There's also the issue of cutting down in the insulin during Ramadan, which predisposes people to lipolysis and ketogenesis. So where does CGM fits in here? It fits in the fact as it captures the market fluctuation and which CMBG will often miss. So that's really the golden utilization of the CGM during Ramadan. So the question is, what are the potential of Ramadan? And Dr. Lisan really went through that in details. So he demonstrated very clearly that it captures the nighttime with the CGM, we can visualize the glycemic impact of iftar, and it offers predictive alerts. So it gives us alerts about what's around the corner, whether it's to do with hypoglycemia or hyperglycemia. It saves the individual with diabetes from the frequent finger prick, and so it enhances their quality of life. It allows subject with diabetes to adjust their insulin, and not only that, actually, Dr. Lisan at that time, he mentioned the fact that CGM educates patients on the impact of specific food types and their impact on their glycemic control. And this is an area that really it took at least another 8 years down the road for clinicians to appreciate that CGM is an educational tool to subject with diabetes. Disregard dose adjustment, disregard insulin adjustment, disregard the level of exercise and its impact on glycemic control. The fact that people are wearing the device, the CGM, it gives them a huge amount of education. And I'll go through that with you later to see how that improves their glycemic control. CGM metrics and CGM metrics that we need to follow is really the same CGM metrics outside Ramadan. So for most patients, they're healthy. We go through with a target glucose between 70 to 180. For most of the time, more than 70%. It's important, however, to individualize, and so we should forget that the frail, the subject who are more prone to hypoglycemia, one can lax on that and make the timer range, the target timer range, 50%. What's paramount is to ensure that the frequency of hypoglycemia is extremely low, and the risk of severe hypoglycemia of less than 54 or level 2 hypoglycemia is less than 1%. So the metrics, these are the standard metrics that we apply for most of Ramadan. It's important that we educate our patients really to how to use the CGM effectively during fasting in order to do two things: improve glycemic control and reduce the risk of hypoglycemia. So how to improve the glycemic control? By really learning about the arrows and how to interpret them. So one should increase the insulin. If there's a steep increase in the blood glucose as shown by arrow pointing perpendicularly upward. The CGM will allow us to respond to high blood glucose level thanks to the alert that it gives during episodes of hypoglycemia. It allows us to do correction doses if our blood sugar is going in the upward direction. It allows us to increase the time between the insulin dose and the meal if the blood sugar is rising. In another word, we take the food if we noted that taking it closer to meals is associated with hyperglycemia, and this improves the glycemic control. Equally, the CGM will help us to reduce the hypoglycemia by omitting or reducing the dose of insulin if the arrow is pointing perpendicularly downward. It allows to prophylactically treat hypoglycemia when we know that it's impending. And again, it allows to decrease the time between insulin dose and the mean for a blood glucose that's falling. So if people are experiencing hypoglycemia after postprandially, then the clue is then to take insulin closer to the meal in order to eliminate this risk of hypoglycemia. So this is really the practical hands-on utilization of the arrows provided by the CGM. However, it is important that the CGM that we're wearing is an accurate CGM. So not every CGM is an accurate CGM. So what are the similarities and differences between the CGMs that we are going to use during the month of Ramadan? It's important that we familiarize ourselves with one or two continuous glucose monitoring devices and becoming expert at those devices rather than to spread ourselves thin, learning about 10 or 12 devices without mastering them. So we have the Freestyle Libre, one of the leading brands of CGM. It has unique features in terms of the fact that it's approved from the age of 2 upward. It can be connected to smart devices, and it can be connected to insulin pump. So we have the Omnipod 5, which is coming soon, and so the Libre Plus has the capability to link to the pump, and this is very important. And the sensor has a 15-day lifespan. Dexcom, again licensed from the age of 2. It's a very small device. It has a 30-minute warm-up time, and again, it's linked to smart devices and to pumps. So there's a long list of CGM devices. I don't have to go through them all, but I've mentioned 2 which are really maybe used extensively. If we look at Freestyle Libre 2, which is, I think, what we have in most of the Gulf countries as a leading brand. As I said, it has a 15-day, the sensor has a 15-day span. It can be connected to tandem slim pump, which we don't have. It can be connected to Omnipod 5, which is the tubeless pump. So these are unique advantages. It has warm-up time of 1 hour, so after 1 hour you can start using it. Children from the age of 2, they can use it. We don't need calibration, so we don't need a finger prick testing. It has a MARD of mean absolute relative difference of 14 days. And I'll go through the MARD with you shortly, because MARD is not everything. MARD is a small part of the story. And we as a clinician, we need to be really, we need to understand the limitations associated with MARD, because every company will come and they will tell us, okay, my MARD is fantastic, it's 8%, it's 7%, so this is a good meter. The answer is no. It's not the MARD that is really the standard of accuracy, and I'll share that with you shortly. So, MARD is how is it tested? We hear it all the time. Those of you who have been in the meeting, Emirates Diabetes Association meeting yesterday and the day before, I'm sure many manufacturers told you, oh, we have a MARD of 8%, we have a MARD of 9%, so our meter is very good. Not really. And I'll explain why. What is MARD to start with? Mean absolute relative difference. So it calculates the percentage difference between each 2 paired results. So if the CGM will give you a value, then you have the reference value from the venous blood or the finger prick, and you look at the difference between them, the percentage difference. And you do that across many values, across euglycemic values, across hyperglycemic values, among hypoglycemic values, and you average them, and that will give you the mark. And then you tell your clinicians, this is the mark, my mark, as a meter. So let me dig deep into this. So the MARD is, the MARD, generally speaking, the lower the MARD, the better is the accuracy. So that's the general principles about MARD. The lower it is, the better it is. And so if you, I'll give you an example. If you have, if you obtain with your meter a value, let's say, of 8.3 millimole per liter. So that's what CGM has given you, 8.3. And then you look at your reference value, capillary blood, venous blood, and it was 8.9. So what is the percentage difference between 8.3 to 8.9? So 8.3 minus 8.9, that's 0.6. Divide 0.6 by the accurate reference value, which is 8.9. That will give you 6.7%. It will give you 0.06, and then you multiply it by 100 to get a percentage. So it gives you 6.7%. So that's the MARD for that particular value, 6.7%. But you need to do that value, and when the blood glucose is 50, when it's 55, when it's 60, when it's 100, when it's 120, when it's 180, when it's 250, when it's 300. So you need to do it across the board. And then you average all those percentages, and then you say, well, this is my MARD. So the lower the MARD, okay, it's the better the accuracy. But there are many drawbacks to this MARD. Because if you do the MARD only in somebody who has a stable diabetes, or somebody who has no diabetes, or somebody who is middle-aged, or somebody who's not on insulin, then the values, there's no fluctuation in the blood sugar. Let's say type 2 on diet. You give them any meter, and their blood sugar is not fluctuating. So the reference value and the meter value would be very similar, and that will give you fantastic MARD. But you can't play with the MARD. You can make it a beautiful MARD when your system is not precise. I'll give you an example. If you do your MARD and the difference between the reference value and the true value and the CGM value is 10 milligram per deciliter. So the CGM is giving me 60, and the true value is 50. So 50 is the denominator, and the difference between the two values is 10. So the MARD is 20%. That's very high. But if you don't use the euglycemic range, and the difference between the true value and the CGM value is still 10, then the MARD would be 10%, because the denominator is 100 milligram per deciliter. If I use the MARD only when the blood glucose is higher, 150, and the value is still, the difference between the two values is 10, then my MARD is beautiful, is 6.7%. So if I want to have a beautiful MARD, then I focus on getting values at the higher range, and I will avoid providing values at a lower end. So in this way, I can manipulate the MARD. So to improve the MARD, what the companies do, they pair results at the high range, and they avoid the low range values. This is what most of the manufacturers do to make the MARD looks beautiful. Is that correct? The answer is no. So are there any better ways of doing it? Yes, there are better ways of assessing the accuracy because that accuracy is very important. In Ramadan, the values that we are getting while fasting, we're going to make important decisions on that value without doing the glucose measure. And because of that, we need an accurate reading. If somebody is in a pump, the pump is going to make the AI of the pump and the algorithm will make important decisions based on the CGM value. So if the CGM value is not accurate, then that pump will not control the diabetes. And if anything, it will be a dangerous pump to use, even though it's AI pump. So what the FDA does, the FDA will say, I want an accuracy based on ICGM, which is integrated continuous glucose monitoring. It's the most rigorous way of assessing the accuracy of the CGM. It focuses on distribution, the individual measurements, and not lumping all the measurements as a mean. And then it's clinically meaningful accuracy across the entire glucose range. So, what does the FDA tell us? The FDA is telling us that our CGM, for instance, and I'll give you an example of that, is freestyle labeling. It fulfills this criteria. So the integrated CGM, overall, your values, more than 87 of value should be within 20% of each other. More than 87% of the values, the CGM value should be within 20% of the true value. Number two, if your value is less than 70 in the hypoglycemia, and the hypoglycemic range, the CGM more than 80 grams per deciliter, more than 98% of the values should be within 40 milligrams per deciliter. And no value, not a single value, should be more than 180 when you are below 70. When you are in the euglycemic range, more than 70% of your values, true values, of the CGM values should be within 15%. And more than 99% of your CGM values should be within the 40%. So this is how rigorous they are. Equally, if your CGM should not give you a drop of more than 1% per minute when the true value is rising by more than 2 milligrams per deciliter per minute. So which means the CGM is going one direction, even by 1 milligram, while the true value is going by 2 milligrams in the other direction. So this is how rigorous they are. Equally, no value should be should show you the CGM is going down by 1 milligram per deciliter when the true value is going by 2 milligrams per deciliter. These values should be less than 1% of the entire readings over the 24 hours. So this is the integrated CGM, and not many meters have this passed through this rigorous assessment of CGM. So integrated CGM during the month of Ramadan, the technology and the guidelines. So the general guidelines will tell us the CGM should be used in people on basal bolus insulin injections. The guidelines will tell us CGM should be used in subjects with basal insulin. More recently, the data is telling us the CGM should be used in people on non-insulin therapy. Why? Because it improves their glycemic control. So this is the data on subject on prandial insulin in green. By just wearing the CGM, your glucose levels will improve over 6 months. If you're taking basal insulin, this is in blue and in red. Again, the values will improve over time. If you're not on insulin, and this is the blue here, simply by wearing the CGM, your values will improve. And you may ask, why are they improving simply by wearing the CGM? Because the CGM is a tool between your hands, which is giving you education 24 hours a day. It's giving you an education about the value of the exercise. When you see your blood sugar is very good, you remember, okay, the last half an hour I've been walking. So walking is very good for my diabetes. Or no, my blood sugar is horrible, it's 300. Why? Oh, in the last half an hour, I had a pasta, carb. So next day, I'm not going to have a carb. I'm going to have a chicken with some vegetables and look at how beautiful is my blood sugar. So that's really how the CGM is changing the behavior of the individual in fasting and in non-fasting status. So applying the CGM guidelines to mitigate hypoglycemia in high-risk patients during Ramadan. This was a subject of a beautiful study by my colleague, Dr. El-Had, in Doha, on the behalf of the ProFast IT study group. So they look at the value of CGM in mitigating hypoglycemia during fasting using freestyle Libre system, following dose adjustment, following education and people on insulin or sulfonylurea. So these are high-risk patients. And what Dr. Al-Had has shown is the following. To start with, they used the CGM, the Freestyle Libre, and their objective was to make sure that the risk of hypoglycemia is absolutely minimal when the patients start their fasting in Ramadan. So let us look at their data. So this is the data about sulfonylurea. And what they showed very clearly, before Ramadan, the timer range was 67%. By using CGM, they maintained the timer range. Actually, during Ramadan, it was 69%. So fantastic data. How about time below range, the hypoglycemia? For Ramadan, it was 4%. By weighing the CGM, it's only 2.2%. And the average glucose values, again, were brilliant in Ramadan, 153 compared to 150. Glucose management indicator, 7%, 6.9%. So really, the CGM was very impactful in mitigating hypoglycemia and ensuring safe fasting. They looked at subjects on basal insulin, and again, they came up with similar data. The risk of hypoglycemia was not different during fasting, and the timer range has, if anything, has slightly increased. So Dr. Lahad and his colleagues concluded that structured education with adjustment of dose of glucose lowering CGM glucose monitoring can effectively mitigate the risk of hypoglycemia in patients with type 2 diabetes during the month of Ramadan. The CGM in patients with diabetes and patients on a number of medications, metformin, DB4 inhibitors, SUs, insulin, basal, and premixed insulin, GLP receptor agonists. And they used integrated CGM, Freestyle Libre 2, with real-time alarms to self-monitoring for at least 3 months before the recruitment into the study. And what they showed our colleagues from Saudi Arabia is the following. Before Ramadan, for the 3 months, the timer range was about 43%. During Ramadan, the timer range was 52%. So if anything, the timer range during Ramadan has improved, and the time below range is absolutely a minimum. So so essentially, the use of CGM has improved patient outcomes. So Ramadan fasting could improve glucose levels in type 2 diabetes with low incidence of hypoglycemia. So to summarize and conclude, ladies and gentlemen, CGM provides a safety net, then self-monitoring with glucose, timer range, and time below range are the most relevant metrics to use. Education on trends and arrows is very important. Pre-Ramadan planning with CGM data reduces acute complications. Breaking the fast if the glucose less than 70 remains very important. Individualization during Ramadan is extremely important to maintain safe fasting. So to conclude, CGM is no longer an optional luxury, but it's a game changer in day-to-day diabetes care, more so during Ramadan. CGM empowers patients with real feedback. So it's real feedback fostering safer, faster. Healthcare providers, us as a clinician, we need to be proficient in interpreting Ramadan-specific AGP reports, and the technology, when combined with structured education before Ramadan, optimizes outcomes of patients. So take-home message, ladies and gentlemen, diabetes technology, including CGM, is appropriate for any patient as long as the patient wants it. We, as healthcare professionals, need to be open to and up to date with the new technologies. Use of CGMs has expanded to non-insulin users, more so during the month of Ramadan, with the proven glycemic benefits. And on that note, I'll conclude my presentation, and I'll be happy to answer any questions that you may have. Thank you very much for your attention.
Thank you very much, Dr. Tariq, for this informative lectures. And as you mentioned, pre-Ramadan education plus technology will help our patients to fast safely without or with minimal complications. Till now, only one questions from Kabir. Please suggest what modification should be made to insulin pump profile setting if patient with type 1 diabetes wants to fast.
Yeah, it depends. Obviously, my colleague, Dr. Walid Al-Dahi is going to address the pump in type 1 diabetes. So I don't want really to step into his boundaries.
Totally agree with you. Yes.
But anyway, depends on the variety of the pump that you have. So there's the automated pumps and the manual pumps. And Dr. Dahi will enlighten us on the use of these pumps for safer fasting of patients with type 1 diabetes.
Okay, Dr. Tariq, I think no more questions. Your lecture was clear and very informative. Thank you, Dr. Tariq, to be with us in this webinar. And we will move to the second speaker. I will introduce our second speaker, Dr. Walid Al-Dahi. He is president of Kuwait Diabetes Society, and he's consultant in endocrinology and diabetes at Mubarak Hospital in Kuwait. His talk will be about type 1 diabetes fasting challenges and opportunities in the new technology era. Dr. Walid, welcome, and the mic is yours.
مساكم الله بالخير جميعا. Thank you for getting me in this beautiful program, and thanks the sponsors and the guide for including me, and salam khas لدكتور طارق. I couldn't say hi to him before this lecture. مساك الله بالخير دكتور طارق. It's always difficult to speak after Dr. Tariq because he's thorough and also covering too many things and making my life also sometimes easier after giving his lecture. I'll try to share my my slides. I don't know. I don't see share button.
Down, Dr. Walid. Arrow, green arrow, please. And just for audience, just to put your question or write your question in QA section, please.
don't see the share button here.
Down, Doctor.
Record slow rights. I think. Was share here. Okay. I hope you can see my slides.
Okay.
And my slides is on.
Yes, Dr. Walid. Please
Thank
go
you,
ahead.
Mr. Chairman. Thank you, Mr. Chairman, for your kind introduction. And مساكم الله بالخير من الكويت. Today, my one fasting challenges and opportunities in new tech era. Because of the time, I elected to make my slides very simple, just to raise points that we need to tackle with type 1 diabetes, and we're going to talk about it. So the question that always come, just to spar. Yes. So the question that comes always to the physician mind is, should adolescents with type 1 diabetes or anybody with type 1 diabetes fast during Ramadan? This is a very difficult question, and we still have many of our colleagues in primary care and also specialists in this field. They feel difficulty in terms of asking a type 1 diabetic patient or making decision for them to fast. So how many physicians agrees on adolescents? And this is basically taken from the ISPAD Clinical Practice Consensus Guideline 2022. It's taken like reasonable glycemic control, good hypoglycemia awareness, and the willingness to frequently monitoring. And these are the three things that make physicians agree on adolescents to fast Ramadan. And we, at the end of this, we know that this is probably not enough. So there's a survey also done by the same paper indicating that almost 80% of physicians looking after children and adolescents with diabetes would allow them to fast if they wishes. So it's a two-word sword with two sides. Sometimes just letting them fast because they want to fast and they are insisting, sometimes it's dangerous, as we saw from the previous lecture. Dr. Tariq clearly stated how much controlling glucose during Ramadan is not easy, and also at the same time need to be looked after in a better way. So this is basically what we have. Now we know from the EBDR study, one of the biggest study looking at diabetes and Ramadan, and we know that more than 40% of type 1 diabetic, and nearly 80% of type 2 diabetes fasted more than 15 days. And we know that whenever you say to your patient, probably most of them, they will fast. And this is because of the pressure of the religion and pressure of the family, where everybody is fasting and the patient is feeling that he wants to fast. Hypoglycemia is one of the big issues in fasting Ramadan, as it's shown previously by Dr. Tariq. And we know that hypoglycemia in type 1 is basically more, according to the EBDR, looking at increase in hypoglycemia in type 2 and type 1 the same. So risk stratification for type 1 diabetes is one of the most important things that you have to look for. And these include many factors. I know most of you know these factors, including pre-Ramadan glucose, duration of type 1 diabetes, hypoglycemia risk, level of hypoglycemia awareness, diabetes-related education, motivation, ability to take appropriate decision-making, the feasibility of access of continuous glucose monitoring, and this is one of the pillars now of management of diabetes, especially during Ramadan, and also the use of the advanced insulin delivery technology, as mentioned by our previous speaker. So this is the crucial factors that you have to look for. Now, when you look at evidence and guidelines, we know that the 2026 updated IDF-DAR risk calculation included type 1 and late onset diabetes in adults as a group as one. And they also mentioned that CGM introduction with an advanced score of -0.5. So if you actually add CGM to the equation of the calculation of the DAR risk calculator, you're actually going to have a -5, which actually help many patients to have successfully chosen to be to have ability to fast. So what are the potential complications of fasting Ramadan type 1 diabetes? Hyperglycemia, hypoglycemia, DKA, and thrombosis episode. And this is basically for all diabetics, type 1 and type 2. But these are the things that you have to think about when you allow your patient to think, and also dehydration. So the risk association with fasting, mainly hypoglycemia and hyperglycemia, may risk, long fasting episode between 15 and 18 hours undertaken in hot and humid conditions, and this is from the DAR guidelines, and incidence of DKA, which is one of the most important parameters that actually make us not making our patients to fast, and that was usually higher in Ramadan. Now, when you look at hypoglycemia during Ramadan, and this is a study looking at the patterns of hypoglycemia in adolescents with type 1 diabetes, you can see here that most of people, they have their diabetes on the right side, their hypoglycemia during 10 a.m. to 7 p.m. And that goes to answer our friend who asked about the insulin pump and how do we adjust it. That's where we have to adjust our basal and also adjust our insulin sensitivity factors. So in anybody with an insulin pump and want to fast Ramadan, of course you have to change according to the day and a day time of futur and time of suhoor, or breaking the fast and time of starting the fast. And this is where we have to adjust the insulin pump during the day. We know that most of the hypoglycemia between 60 and 70, but 27% in this cohort, went to 50 and 60. So this is basically how the pattern using a flash monitor. So this is from the DAR 2021. And you can see here, this is the key parameters of type 1 diabetes who fasted Ramadan. The study looked at 1,054 subjects. So during fasting, 26.8 fasted the full 30 days, 45 fasted 22 to 29 days due to diabetes-related illness, like hypoglycemia, hyperglycemia, DKA, and 28 fasted 21 days. Hypoglycemia, hyperglycemia, and severe events leading to hospitalization, as you can see here, these are the three important things that you have to look for in these patients. So we know hypoglycemia is more, 39% reported no symptoms of hypoglycemia, 48 reported symptoms of hypoglycemia over 1 to 7 days, and 12.8 reported symptoms over 8 to 30 days. Hyperglycemia, 52% reported, and 16.8 have hyperglycemia over 30 days, and severe events leading to hospitalization like DKA or dehydration, 93.3 did not require, and only 6.8 require emergency room hospitalization. So this is also encouraging that we can push our patients to fast, because there is a window of safety here. So what is missing for adolescents and type 1 diabetes and fasting? And this is a question for everybody who wants to do more research in this part, because we don't have adequate powered randomized clinical trials comparing different treatment regimens and algorithms for dose adjustment. And this is basically very small numbers and scattered, not looking and not comparing. A validated risk score stratification is also needed for this age group. Research into quality of life, focusing on psychological effect and facing peer pressure, and this is a very important in type 1 diabetes, especially during school and outside school, and also in the family, an effect of acute complication during fasting Ramadan. This is very important. This is the lacking in type 1 diabetes. Now, when you talk about fasting, we talk about testing, and testing is important. And we know that to become successfully, to fast successfully, you have to test a lot during the day. This is from the DAR. If we all know this picture, very famous, that you have to do what we call the 7-point testing during the day. Now, we know from our colleagues' studies in our area, like Dr. Ibal Uzairi and Dr. El-Hawari, they looked into, focused and pre-Ramadan intensive education for patients for a type 1 diabetic during, for fasting Ramadan. And then you found here, as you can see, the results: decreasing hypoglycemia, decreased fructosamine, decreased HbA1c in all these patients. So focused Ramadan education is still very important. Now, CGM came to the picture, although it is, came to the guidelines late, and technology was there before. But as you can see here, CGM can help achieving glycemic control. This is from the ADA, and you can use also periodic use. So you don't have, if you have a patient or he cannot afford having CGM all the day, you still can use periodic use, or should you have also a good education as need. So these are the three things that ADA advise. We know that real-time intermittent scan CGM address barriers, convenience, painful, cost. People still don't think it's very important, but when you look at the ADA recommendation on the right side, it says that it is very important, and it actually they emphasize the use of these in patients with diabetes, and the use of also technology in the use. So landmark trials for CGM, we know using different CGMs like Diamond, using Dexcom and BACT and Concept and Concierge, all of them in type 1 diabetes, and they all showed significant decrease in HbA1c, improvement in glycemic control, reduced time in hypoglycemia, sustained reduction in hypoglycemia with no change in time and range, and decreased HbA1c and hypoglycemia with sensor augmented pulse if it is used. So we know now there is big evidence that support the use of CGM in type 1 diabetes. There are meta-analyses, look at studies and the real-world evidence, and we know now real-world evidence is something that we look for, because you can look for many patients, although it's a less level than randomized trial, but this is telling us more practical advice. And you can see here in this real-world evidence using Freestyle Libre that it's used for children and adults, and you can see there is also change in HbA1c in the use. Again, another study looking at hypoglycemia unawareness and hospitalization, and you can see there is reduction in HbA1c, hypoglycemia unawareness, hyperglycemia, DKA, and also admission to hypoglycemia. So the use of CGM in type 1 diabetes is becoming a necessity, and it actually improve the numbers and also reduce events. Again, this is another study looking at recurrent DKA, and you can see DKA event per person, severe DKA, and HbA1c, all reduced when you use CGM in this study, Freestyle Libre, that looking at improvement in overall glycemic control in the cohort of the study. Again, this is a study looking using Freestyle Libre during fasting, and you can see here during pre-Ramadan, during Ramadan, and post-Ramadan, it's actually stable. It doesn't cause lots of insignificant changes. And there is, post-Ramadan, there is no significant alteration in overall glycemic control. So this is telling us that actually having this kind of technology will reassure that the patient is doing well. This is again looking at use of CGM to help patients to act earlier in terms of hypoglycemia. And you can see here, this is 67% in type 1 diabetic patients, fasted days, most of the days. So patients fasted 67% for eligible fasting days with no record of life-threatening episode or severe hypoglycemia or DKA during Ramadan. Again, using insulin pumps is also very important. And this is one of the technology that we actually push our patients to, especially for Ramadan. I mean, we don't start insulin pump before Ramadan because it needs lots of education. But patients who use the pump, we ask, their chances of having successful fasting is more. So this is a hybrid closed loop system managing moderate to high risk individuals with type 1 diabetes during fasting. And you can see here on the left side, this is the pump. On the right side is the MDI. And you can see the difference that with the pump, you have time and range 72.5 versus 50 in the MDI. So that's basically during fasting and a better control with the using of the hybrid pump. What about the this is the conclusion of the same study by Dr. Abdullah Gwehi. For moderate to high risk individuals with type 1, hybrid closed loop substantially improved the safety and feasibility of prolonged daytime fasting during Ramadan, outperforming MDI, CGM, in achieving glycemic and fasting targets. So this is also one of the technologies that we have to adopt in terms of managing our patients. This is from the ADA, a paper published recently, and this is looking for the use of, pump with the automated insulin delivery, AID, comparing it to different modalities. So you can see the red boxes on the left, the AID pump. There are 62 subjects. You can see on the right, the median days fasted was interrupted, was the lowest in the AID pump, which is the automated insulin pump, different than the hybrid. So if you look at the hybrid and the MDI with CGM or MDI with pump or MDI with glucometer with a pump or MDI with a glucometer, you can see it's the lowest interruption 2 days compared to 5, 3, 3.5, and 2.5. Time and range, 73% comparing to the other systems. Time below range was, 2% comparing to the others. And glycemic risk index done in the study was the best when you use, automated insulin delivery. So this is a technology where we have also to think about when we have patients who are coming to us towards using. Now, in this era of technology, we have to look beyond fasting glucose and HbA1c. So I'm sure now you understand there is no endocrinologist or diabetologist should manage diabetes with only fasting blood glucose and HbA1c. You have to go for time below range, time in range, and time above range. And now we have also references for you have to know in terms of percentage and numbers. So from now and then, anybody who don't use these terms, please read about it, put it in your system, look at it, and don't only rely on HbA1c and fasting glucose. And nowadays, recently, we have something called time and normal glycemia. And this is something now is coming toward the literature very strongly. This by itself needs a lecture, but now we are in some patients looking to reach time and normal glycemia. And this is something that is still looked at. There is lots of papers coming. There is we call the very tight control. So here that we are working for our automated insulin delivery. Now we have different deliveries. We have artificial pancreas, closed loop system, bionic pancreas, threshold suspension related programs, and fully closed loop that is actually coming out. Artificial intelligence is coming very significant in terms of diabetes. Mechanical machine learning, there are lots of new literature towards the use of machines that are learning how to manage diabetes even better than the human and better than the closed loop system. Data mining, diagnosis and prediction of diabetes, pharmaceutical R&D, artificial intelligence driven, and health management artificial intelligence driven is the future. Real-time continuous glucose monitoring is advancing. We know that the competition between companies is very hard. With the introduction of many CGMs now, we have to look for many specifics to decide which one is the best. And Dr. Tariq was mentioning, explaining the MARD and the other parameters. Real-time continuous ketone monitoring is something that is very interesting and coming to type 1 diabetes as one of the ways to actually improve control of our patients, and decision support tools are many that comes to help patients to decide how to take the insulin, how much to take and when to take. So this is something that is very intriguing, and this coming years we're going to see different literature and different type of lecture that what we do nowadays. This is the a study looked at trends in number of AI related manuscripts from 2014. It's not from 2000, it's from 2014. You can just see the number of boxes in all parameters: digital biomarkers, blood glucose prediction, classification and task, insulin management. Everything is going toward AI driven research, and we're gonna see different future for type 1 diabetes with AI. Thank you very much.
Thank you, Dr. Walid, for your excellent and informative lecture about the technology. And as you and Dr. Tariq said, pre-Ramadan education and technology will help our patient to fast safely with no or minimal complications. Really, if we compare in last 10 years, the new medications, technology help our patients a lot to fast safely. And we'll go to the questions, Doctor. I think already you answered the first questions, modification for patients, and they can go also through the guidelines clearly mentioned in 2021, how to modify the medications for type 1 and type 2 diabetes, and even for insulin.
Doctor, when we talk about modification of medications for diabetes, in particular type 1, it's a map. So you have to first see how is your patient doing in the normal day, and how can you move around in Ramadan. So Ramadan is shifting of time, shifting of sleeping time, and shifting of time and size of meals. So basal should be changed, insulin factor should be changed, insulin carb ratio should be changed. So you use your usual insulin carb ratio that you use for breakfast, for food, for example. So you have to reevaluate. It's just simply shifting your patient day toward Ramadan time, and this is basically where it is very easy to remember and very easy to follow.
Another question: how does prolonged fasting impact the risk of diabetic ketoacidosis, especially in patients using CGL2 inhibitors?
If patients using SGLT2 inhibitors, it's by itself increase the risk of DKA, euglycemic decay. So this is not related to fasting. So it's entirely two different etiologies. Now, fasting is a catabolic state where it's a stress on the system, And prolonged fasting can also lead to decay in terms of stress and the increase in counter-regulatory hormones. So it is two different modalities. Now, in type 1 diabetes, we don't recommend the use of SGLT2 inhibitors. And if you want to really use it for a specific reason, in particularly cardiovascular or renal, you have to be very careful. You have to explain to your patient. Nowadays, with the availability of CKM, which is continuous ketone monitoring, that would be also one option that may be used. But overall, we don't advise the use of SGLT2 inhibitors in type 1 diabetes.
Another question, what advice for type 1 diabetes patients for fasting? I think already you mentioned that. Any other advice, Dr. Waleed? What advice for type 1 diabetes
just in general,
for
remember,
fasting?
when you talk about fasting, this is a general talk, and deciding who will fast. Fasting decision is made between three persons: patient, doctor, and his religious reference. Sometimes doctor work as a religious reference, which is wrong, and many doctors think that they understand religious reference, and they tell the patient, no, it's okay. And this is the religious reference himself, Sheikh or Deen or Sahib Deen, he also see the patient look like, well, he tell him, go ahead and fast. Also, when we in Kuwait, I did many times, we do, me and my colleague, one of the Mashayikh al-Kuwaiti, we do together counseling for type 1 diabetes, and nobody should take the position of the others. Now, patient himself is the one who actually gonna convey the message between the two or his reference. We as doctors, we have to think about if my patient can fast, do through what we do through calculating the risk. And this is, I encourage you to use the DAR calculation. I encourage you to look at the risk factors that I mentioned, which is also mentioned in the DAR, and then decide if the patient can fast or not, and don't put the patient into dilemma between the two.
Yes, and always we have also to mention to the patient, ومن كان مريضا أو على سفر فعدة من أيام أخر يريد الله بكم اليسر ولا يريد بكم العسر. يعني just to make the ease to the patients not to be in difficulty or put them in dangerous because of the fasting. وإن الله يحب أن تؤتى رخصه كما يحب أن تؤتى عزائمه. We have to convince our patient if the fasting is risk for them. Other questions, yes, Dr. Waleed?
Yes, that's a reassuring thing.
Yeah. So what is the real world incidence of thrombosis during fasting?
I mean, the incidence of thrombosis is very low, and it was shown in the EBIDYAR study. I don't remember the percentage itself, but it is not very high, and it's mainly in patients with type 2 diabetes with previous risk factor for thrombosis. So it doesn't happen in type 1 diabetes, very rarely happen in type 1 diabetes.
And also we are now in the beginning of the summer, at the end of the winter, the dehydration is the risk for the thrombosis, and this year things will be fine, not compared to the summer, for example, on June or July. Well, most of the time, we'll fast 10 days or 12 days on February, and then the half of the March. And this will be more easier for our patient because, the summer is high risk of dehydration compared to winter or at the transition.
Important thing is somebody with cardiovascular background have to be advised very well to maintain his medications that related to his cardiovascular disease, because that's a very important thing, because in Ramadan many patients are non-adherent to their other medications.
Yes, especially diuretics and some antihypertensive, aspirin, clopidogrel is very important just to keep all medications. Another questions, Dr. Walid, does taking GLP-1 agonist cause complications while fasting?
GLP-1 agonist is not indicated for the use of type 1 diabetes, but we do use it in someone with type 1 diabetes have obesity. So it doesn't cause DKA, although there are some reports very rarely when they start the GLP-1 to cause DKA, but it's not very clear. We don't advise starting GLP-1 prior to Ramadan. So this is not something that you don't want to do any major change for the patient before Ramadan. So I postpone Ramadan because Ramadan by itself is a big change, and you're adding a new medication, that's another big change. If you have GLP-1 during Ramadan, you have to warn your patient about drinking enough water, side effect of the medication. Don't raise your dose because it's Ramadan and you want to lose weight by yourself. You have to discuss it with your doctor, because many patients, they do that by themselves. Many, especially our beloved girls and women, they start by themselves GLP-1 Ramadan. They said just to avoid the weight gain in Ramadan, and that also can happen with diabetics. So using GLP-1 during Ramadan, it may cause side effects related to GI, and that will make patients either vomit or having diarrhea, or patients, because of they are not eating well, they develop hypoglycemia because of the insulin. So it is something that you have to think about very carefully with your patient, and not start it before Ramadan, and keep it, if it is new, keep it after Ramadan.
Okay, doctor. When to say to our patient to break their fast immediately during the daytime?
Yes. So breaking the fast is very simple. If the patient feeling tired, even if his sugar is okay, and he's having diabetes, feeling tired, he should, and cannot cope, he should break the fast. If his blood glucose below 4, that's definite hypoglycemia, he should fast. If it is below 5 and he feel tired, he still also should fast, break the fast. And also we have to remember and remind them that breaking the fast is basically something good you do, because if you don't break the fast and you become sick, you will be admitted to the hospital. At the end of the day, you will not be able to read Quran, or تصلي, and or do anything. So Ramadan is not about only fasting. It's about too many things to do. You cannot, do lots of things if you are sick in the hospital. So if you have any feeling tiredness, especially diabetic patients, because diabetic patient could have anything. They could have, somebody who's, and we tell him you are feeling tired. I'll go sleep. Well, also, so feeling hypotension, hypoglycemia. If your CGM is that
So with the gestational diabetes, what are clinical criteria to decide if fasting is safe?
Now, if there is a pregnancy and fasting, she should not fast, because pregnancy by itself is a stress, and diabetes by itself is a stress. And we don't ask our pregnant lady fast. Some healthy young girls who are just pregnant, they have type 2 diabetes, they may fast. Type 1 diabetes would prefer not to fast if they are pregnant, because there is 2 diseases now. But in general, if she is pregnant, it's better to fast.
Okay, Dr. Wali, any home message to give to our audience? Because other questions not related
I would like
to
to thank you, my chairman, for your kind introduction, and thanks everybody for the good discussion, and thank the sponsors. Remember that it's not anymore that patients with type 1 diabetes cannot fast. So if you are a physician and have type 1 diabetes, discuss with your patient. I know it's difficult because it will require you many minutes and time to educate. It's easier to say not to fast. And there is some doctors that I have my patients, sometimes they come, Dr. Gali, don't fast, because he don't want to spend time with him. But remember that type 1 diabetic patient can fast, use the new technology in terms of CGMs or insulin pumps can help us. There is future which is gonna do better for in terms of technology and type 1 diabetes, in terms of accuracy and the way of handling insulin pumps in terms of closed loop, or also biogenic pumps, also CKM, which is the continuous ketone monitoring. Imagine if you have all of this to type 1 diabetic, they will be easy. But now they can do fast with a little help and education before Ramadan.
In our study, Dr. Walid, we did a study in 2024. Okay, 51% of our type 1 diabetes fasted whole month of Ramadan safely, alhamdulillah. Our study and also pre-Ramadan education, including written plan for our patients. Alhamdulillah, 51 fasted safely, and 89% of our type 2 diabetes fasted safely also during Ramadan. And from our experience, even type 1 diabetes, they can fast if they receive full educations and they are following our recommendation, and CGM really help safely to fast safely.
Remember,
Thank you.
regarding education.
Oh, yes.
Sorry. Remember something regarding education. They think it's going to be a very heavy education. No, because most of these patients, they know diabetes. It's just, a checklist where you do it with your patient. How I adjust my dose, how I deal with when I'm sick, how I deal with my blood sugar is low, what I do with my CGM, what I do with my pump, how can I adjust my insulin injection. What is the symptoms of hypoglycemia? Again, what are the symptoms of hyperglycemia? This is where the focus of education, where it actually make it successful, like the study of our chairman.
Yes, yes, Dr. Walid, and it's very important also to send posters, educations by Arabic to all of our patients. And alhamdulillah, we are doing that. All of you can follow our social media, and you will find all posters by Arabic written clearly and in simple language for our patient to guide them either type 1 or type 2 diabetes. Dr. Walid, thank you very much. And Dr. Tariq also for excellent contributions in this webinar. And on behalf of our GAID, a special thank for you, Dr. Walid and Dr. Tariq, and also for Abbott for their sponsorship. Thank you very much.
Thank you.